welcome to all of you joining from across the globe to this scientific panel on program implementation. My name is Anton Mbonya. I'm a professor at the College of Health Sciences, Makerere University, and formerly Director General of Health Services at Ministry of Health, Uganda. The COVID-19 pandemic, as you all know, has placed substantial strain on health systems across the globe. Competing health priorities, service disruptions, stockouts, and lockdowns have interrupted the provision of voluntary family planning. Our discussion today features 4 panelists who are on the ground innovating and implementing to ensure that family planning services still reach the clients. We will hear concrete examples of how policies were changed to issue prescriptions for contraceptives by phone, how quality of care was upheld by online mentoring of providers and expanding self-care options, and how partnerships with the private sector is overcoming delivery challenges. We are also going to ask our panelists to identify what has worked and what has not worked, and what recommendations they have for those wanting to adopt similar approaches as they have done in their respective areas. In Uganda, we have had challenges of lockdowns, we have had limited access to family planning, and this has affected clients, especially the vulnerable and the poor. The Ministry of Health of Uganda developed a continuum of care guidelines with an RMNCNH component. UNFPA came in and supported outreaches for family planning with community-based distributors, and JAPIGO did the same. We are yet to evaluate the impact of these interventions. So I will request that each panelist presents a brief overview of the context, program intervention, key results, challenges, and lessons learned in 6 minutes. And after each presentation, I will ask the panelists 2 follow-up questions, especially focusing on challenges, lessons learned, and implications and recommendations for scaling up in the implementation context. So I have 4 panelists who are going to take us through. The first one is Dr. Ishu Diop Toure, who is the Senegal Chief of Party and who will share an experience on facilitating the private sector inclusion in Senegal during the COVID-19 response. Dr. Toure, you have the floor.
Hello, thank you, Mr. Moderator. I'm going to start my presentation now. Hello, good afternoon, good evening to all participants. I am Dr. Ishu Diop Toure. I work with Shops Plus in Senegal. It is my great pleasure to share the experience that we've had in facilitating private sector inclusion in Senegal's COVID-19 response. I'd like to tell you about the context in which we work. Shops Plus is a USAID program that's been implemented in Senegal since 2015 with the goal of enhancing the role of the private sector in providing quality information, products, and services for family planning and other health services as well. Shops Plus also focuses on developing government capacity to engage with the private health sector in order to achieve objectives related to universal health coverage. Senegal was not spared by the COVID-19 pandemic. Its first case was reported on March 2nd, 2020 in a private facility, after which the government mobilized all actors in a multi-sectoral response. Shops Plus worked to facilitate private health sector participation. I'd like to talk about our response, which included several actions. We worked to ensure that the private sector's voice was heard at all levels of health system decision-making in Senegal. We worked to build the capacity of private providers around prevention, case management, and control of COVID-19. This also involved communication about safety measures. We also helped private providers weather financial hardships by developing risk mitigation plans, and we supported the government's efforts to conduct a larger number of tests through private laboratories and by implementing risk communication. Shops Plus additionally introduced adaptations to minimize disruptions to private sector distribution of family planning products and services. We observed very promising results. The Private Sector Alliance, which brings together all members of the private sector in the health field, it was included in epidemic management committees at the national and regional level. It worked on planning, organization, and coordination of different activities. We trained over 1,000 private providers, and we equipped 250 private facilities with personal protective equipment. This allowed these private facilities to continue providing services in this time. Next slide, please. Shops Plus conducted an online survey mapping capabilities of private sector labs that were equipped to perform COVID-19 tests. We worked with the Ministry of Health and these private sector labs to create public-private linkages. And here's the most important thing. Shops Plus was able to work with different laboratories and use social marketing to distribute over 3 million condoms, 700,000 oral contraceptives, and 70,000 subcutaneous Depo-Provera injectables. All within our work to offer family planning services. We helped 65 private providers mitigate changes in financial flows and develop risk mitigation strategies during this time as well. We did face a number of challenges. The first one was related to organizing online trainings. We had participants throughout the country, and we don't always have a good internet connection. The service providers who were participating were also not always available. Next, lockdown led to a ban on inter-country travel, and social distancing required adaptations to marketing and social mobilization strategies. We resorted to telemarketing with a more adapted distribution system. Next, there were the protocols for COVID-19 treatment, and these didn't originally include the private sector. Now let's pass to the lessons learned. Despite the presence of the platforms in which they were participating, the private sector continues to struggle to be heard. This means that in this area, we need to continually reinforce the importance of private sector engagement. It's essential that a better understanding be had of the services the private sector delivers and the resources held by the private sector. When public sector services were focused on treating COVID, many flocked to the private sector for other needs. We need to work so that the private sector continues to offer a wide range of family planning methods, especially for young people. Ladies and gentlemen, I've just shared the experience that we had in facilitating private sector engagement in family planning during COVID-19. I'd like to thank the USAID in Senegal, the Senegal Ministry of Health, and the Shops Plus headquarters team. Thank you so much for your attention.
Thank you, Dr. Ture, for that excellent presentation and exciting presentation. I have two questions for you. One is, what strategies did the Shops Plus employ to engage the regional medical officers that were hesitant to engage the private sector? The second question is, are there any adaptations made to the program as a result of COVID that you think will remain permanent? For example, do you envision that the sales strategies of the SMO will always include telemarketing moving forward? Please respond to those questions in 2 minutes, if you can. Thank you.
Thank you so much, Mr. Moderator. I will try to respond quickly. Your first question was about the strategy that we employed with regional medical officers. We worked with the Ministry of Health, who communicated with all of these regional medical officers to work on epidemic management. We also did work on the ground to talk with people who are reticent in working with the private sector. We shared information with them. And finally, this led to the adoption of a plan, an action plan. Next, we also developed an online platform. And actually now I'm responding to your second question, the strategies that we're going to continue to use post-COVID. I would say that we really disrupted our way of doing things. I mentioned that we moved trainings that had previously been in person online. As for social marketing, we developed this telemarketing strategy that was based on websites, as well as phone calls and WhatsApp. These strategies showed that we can actually get great results, and we can gain time by using these very efficient methods. And I think that we will continue using some of these methods in the future.
Today for responding to those questions very well, and thanks for the overall presentation, sharing us the experiences in Senegal. Let me now turn to Dr. Tabinda Sarosh, Country Director Pathfinder from Pakistan, and she will take us through she will take us through alternate family planning, care pathways, digital supportive supervision, and mentorship model to ensure quality of family planning services in Pakistan.
Thank you, Dr. Anthony, for inviting me. Good morning, good afternoon, and good evening to everybody. As Anthony said, I am the Country Director for Pathfinder International in Pakistan, and also the Project Director for Naya Kadam, which is a consortium of 6 local international organizations supported by the Bill and Melinda Gates Foundation, and focuses on increasing access to post-pregnancy family planning, particularly for young women. If we go to the next slide, I would like to discuss a little bit about the background. Pakistan confirmed its first case of COVID-19 on 26 February 2020, and within 6 weeks, confirmed cases had surpassed 5,000, and this was with very selective and limited testing in the initial days. In February, Naya Kadam in Pakistan was in its accelerated phase of service delivery, following key policy gains around post-pregnancy family planning that had strengthened the role of the community health workers and the providers through a robust curriculum revision, LHW referral strategy, as well as guidelines on DMPSC for LHWs and high-level policy roadmaps for post-pregnancy family planning. We were already working with more than 7,500 lady health workers and more than 1,500 public and private service providers. So if you go to the next slide, please. Previous global experience from fighting with Ebola epidemic had already established that the number of unwanted pregnancies and unsafe abortions was bound to increase. And this was being correlated by the insights from the field. To address this, Naya Kadam initiated digital supportive supervision of the providers to develop knowledge and competency of providers on COVID-19 and to ensure continuity of SRH services, particularly postpartum family planning services during the pandemic. This required us to do a rapid needs assessment with the providers and a rapid assessment of user-friendliness of the digital communication technologies available. WhatsApp proved to be the most popular and accessible digital channel for the frontline service delivery cadres, as well as the community health workers. If you go to the next slide, please. So the homework required us to redesign the session content and style, understand the implications of cybersecurity threats, and ensure an interactive approach to avoid participation exhaustion. We carried out virtual trainings of the providers using live chats to share training content, case studies, and videos, and to facilitate discussions and question-answer sessions. We followed that up by a series of digital mentorship interactions that were mostly one-on-one and focused on refreshing PPFP knowledge and skills. These training groups and mentorship platforms took a life form of their own, as not just knowledge, but ground issues in the field were also shared that led to collective solution seeking, and the project was able to identify and respond to the constant need for PPEs and PPFP equipment in the facilities. If you go to the next slide, please. So in a nutshell, we had developed a virtual learning system that included group trainings in the beginning and was followed by one-on-one and group mentorship sessions. If you go to the next slide, we'll be able to see some assessment of the trainings. The trainings showed satisfactory knowledge uptake. Next slide, please. So the trainings showed satisfactory knowledge uptake through pre and post testing and also good feedback on the Likert scale. Currently, we are using a qualitative research approach, FGDs and IDIs mainly, to further evaluate the digital training and mentorship approach and its utilization in the field. If we go to the next slide, please. So what were our biggest challenges? Needless to say, in a context like Pakistan, biggest challenges were power supply interruptions and digital connectivity and the risk of information leakage. We took measures to mitigate the risk of breach of confidentiality and privacy. So if we go to the next slide, just to see what were our key takeaways, we felt that the approaches and the principles that we were following were adaptability, flexibility, and responsiveness. Digital mentorship platforms became an ideal and cost-effective way to connect with providers for constant mentorship and motivation. However, live monitoring of the competencies is ideally done in person. Thank you so much. And if you have any questions, I'm happy to take them here, or later on, you can reach me at email. Thank you so much.
Thanks, Dr. Sarosh, for that nice presentation. It's now my pleasure to turn to Dr. George Barije, who is technical advisor at PASS Uganda. And he's going to take us showcase innovations in self-care, lessons learned from applying virtual tools and approaches for increasing client self-injection, subcutaneous DMPA in DRC, Madagascar, Senegal, and Uganda. Dr. Barija, you have the floor.
Thank you, Prof. Good morning, good afternoon, good evening. As introduced, I'm George Barija, and I work with PATH as a regional technical advisor for Anglophone countries on our DMPAC Access Collaborative project, which is implemented by PATH and JSI. I'll share with you on innovations in self-care, focusing on lessons learned from applying virtual tools and approaches for increasing DMPAC self-injection in DRC, Madagascar, Senegal, and Uganda. Those are some of the names for our colleagues who contributed the success of this work that I'm sharing with you. While at PATH, we aim to improve access and options to a variety of contraceptive methods. The product I'm talking about today is called subcutaneous depomedroxyprogesterone acetate, or DMPASC. This is a prefilled all-in-one injectable contraceptive that protects against pregnancy for 3 months, known by the brand name Cyanopress. It is a lower dose of the same drug that is given intramuscularly, also known by the brand name Depo-Provera. The game-changing aspect of DMPASC is that it allows women to self-inject. It is the first widely available self-injectable contraceptive, and as you may be aware, WHO strongly recommends self-injection as a self-care approach. During a pandemic like COVID-19, self-injecting at home can also help reduce women exposure to illness by reducing their trips to crowded facilities for their injection. Self-injection can also reduce pressure on the overloaded health systems, given fewer clients' visits for injections. Training both health workers and clients is key to successful self-injection. Once health workers are trained, they can help women to learn to inject on their own. However, health workers' training and supervision can be challenging and expensive. For example, off-site training can leave facilities short-staffed, and on-job training and supervision can take longer to roll out. Most times, it is interrupted when clients' load is heavy. And now we have been faced with another challenge during COVID-19, how to provide training and supervision to maintain essential health services like family planning. So, innovative training and supervision approaches were introduced in 4 countries, in the DRC, Madagascar, Senegal, and Uganda. In all the 4 countries, national DMPASC scale-up is in process, including through self-injection. All these country training or supervision activities were focused on self-injection counseling, except for Uganda, where they took a full 10-lesson e-learning course. It's important to note that form evaluation were conducted for all countries except DRC. So more than 6,500 health workers were trained across the 4 countries. In DRC, training of master trainers in small groups was conducted in Kinshasa, and this facilitated the distance learning using video conferencing and online materials, and sometimes in-person training for provincial and health zone trainers, who in turn trained health workers on site at facilities during routine supervision. This targeted public and private health workers. The key results were that over 4,600 health workers are trained across the 13 provinces. And this was led by Pathfinder International in collaboration with the Ministry of Health. In Madagascar, the approach focused on decentralized training for injection experienced providers by orienting them on the DMPASC basics and providing follow-up supervision. The facility in charges were given a 3 hours orientation on DMPASC basics during a routine monthly review meeting. They then taught back the information to FP providers at their facilities. The training, along with the follow-up activities, were guided by the DMPASC job aid, which was widely distributed in all sites. These targeted public health workers with DMPA injection experience, and the key results were that 100% of all the health workers from 35 districts were reached with virtual supervision, in contrast with in-person, which could only reach 40 to 60%. Please note that 81% of the health workers were able to correctly demonstrate self-injection. And this activity was led by GSI in collaboration with Ministry of Health. Then in Senegal, they introduced e-learning lesson on counseling clients for self-injection, followed by post-training supervision. However, there was on-job training for health workers that were unable to access e-learning. These targeted public sector health workers with DMPA training, but who did not have training on self-injection. The key results were that over 390 health workers were completed the e-learning course, and 347 received on-job training. This activity was led by PATH in collaboration with Ministry of Health. Uganda, the e-learning course, they introduced an e-learning course with 10 lessons, including lesson on counseling clients for self-injection. Then the health workers who participated in hands-on practicum. This targeted both public, private health, and private health workers, including community health workers who had not received DMPSC training. The key results were that over 270 health workers completed the course, and 70% of the health workers demonstrated injection competence without practice or guidance after the course. 89% scored over 80% on DMPSC post-test. So we noted that there was fairly low scores on the general FP knowledge assessment. This quiz was included in the evaluation, but the content had not been covered in the course. Just 51% of the participants scored above 80%, and this highlighted the need for general FP knowledge or training. And this activity was also led by PATH and in collaboration with the Ministry of Health. There were a number of challenges that were noted, and for any program needs to be able to consider these issues in advance and to identify possible solutions. One of them was unstable electricity and internet or phone connectivity, limited access to smartphones or computers to take e-learning course, and health workers found challenging finding time for e-learning or on-job training or supervision calls during facility operating hours with clients waiting. Then also the supervisors found it a challenge to be able to gauge health workers' performance during simulated conversation or role play over the phone. Then again, also e-learning is most effective for people who are literate in English or French speakers, then leaving out the others who are more fluent in the local languages, for example, the community health workers. Then encouraging e-learning participation, providing orientation and tech support, and monitoring progress can be labor intensive and requires adequate staffing. So what were the lessons learned? So for virtual training and supervision programs, often we work best with several key elements. Technology support for health workers is key. Then support with mobile data plans to help ensure connectivity is also important. Monitoring of health workers' progress and sending reminder messages is also important. And recognition for completion, for example, providing a certificate also motivates the health workers. Then lastly, but not least, post-training, follow-ups, support supervision, and guidance is important. Thank you very much, and thanks for listening to me. For more information, you can visit our website and get more of any information that you require. Over to you, moderator.
Thanks, Dr. Barije, for that presentation. I have two questions for you. One is that of all the challenges you have shared with us, which one of the biggest and what did you do to address it? The second one, are the approaches sustainable? Are there plans for them to continue and scale up after the pandemic? George, if you could respond to those questions in 2 minutes, please.
Thank you, Prof.
Thank you.
The biggest challenge was internet and cell connectivity. And we addressed this by encouraging them, the participants or the health workers, to access phones from peers. And also we supported mobile data plans. Then for the next question on sustainability, we are working with the Ministry of Health in the respective countries to scale up these innovations, and we are working on solutions to the challenges that were identified. For example, we have moved the e-learning course platform to a platform that has an application which allows people to take the course offline. Then their course progress is uploaded when they reconnect. And we're also exploring training approaches that use audio only or text, in which the health workers only needs a basic mobile phone, and which can actually be afforded by most health workers. Over to you.
Thanks, Dr. Barije, for those responses. And thanks for the nice presentation and sharing with us experiences from the 4 countries. Let me now turn to the last presenter, our panelist, Dr. Tamina Ardugaish, who is the head of the Society of Obstetrics and Gynecology. And she will take us through on telemedicine in Oman. And this should take 6 minutes.
Thank you, Dr. Anthony, for the kind introduction. And thank you for inviting me to share our experience from Oman in the telemedicine hotline. So I'll be sharing with you today Oman experience in establishing a telemedicine hotline in obstetric and gynecology consultations during the COVID-19 pandemic. For people who don't know Oman, so Oman is a very beautiful country in the southeastern part of the Arabian Peninsula. We have obviously were affected by the COVID-19 pandemic, like all the world. And our first case was identified in 25th of February, 2020. And currently we have a total number of cases of more than 130,000 with more than 1,500 deaths. So what we have done started at the start of the pandemic, or just after, the start or the hit of the pandemic to the whole world, we have discussed the option of establishing a hotline on telemedicine to address consultations and issues related to obstetric gynecology for all women in the country. So this initiative was actually a collaborative initiative from the UNFPA and WHO Oman, in addition to Ministry of Health and Oman Society of Obstetric and Gynecology. Obviously, it's a joint collaborative approach, and we have started it from May 2020 until December 2020. We have established this hotline to serve all women who are either pregnant, postpartum, lactating, or obviously in the reproductive age group with issues related to either contraception or postmenopausal issues. We have a consultant who is responsible for guiding and providing phone consultations and reassurance to all women who approach us in Arabic and in English. So the main objectives of this hotline is to provide advice on preventative measures to all women who are worried about contracting the disease, or deliver clinical advice to women who have simple complaints in order to reduce the unnecessary visits to the healthcare facilities. Obviously, we have a lot of, due to the overload in the healthcare system, we have a lot of major, I would say, either postponement in the elective cases or in the appointments and outpatient appointments. So a lot of women, they did not really get the they did not address their healthcare issues that they needed from before because of that. So this hotline has helped actually in providing, guiding women and how to address their healthcare issues related to obstetric and gynecology, and they've also over-counter medications if needed. We have recruited 2 senior consultants and experienced midwife to do the job. What we have done is basically an extensive media advertisement through Oman TV, radio, and the various social media platforms to spread the news regarding the presence of this hotline so that the maximum women will benefit from this initiative. We have used the Ministry of Health call center, which is already existing, to make it easier for us to get the calls. And we will get the calls during working days, obviously. All the calls will be screened by the midwife initially, and if there are any clinical consultation, then she will forward the calls to one of the consultants, and a direct contact with the patient or with the woman directly with the consultant addressing her issues. So as I said, we have run this service from May till December, end of December 2020. And the total number of calls were around 609. There were almost 50 of them are obstetrics related calls, whether they are issues related to fetal conditions or to the mother herself. And we have also around 50% gynecology calls. Most of the gynecology calls will be related to family planning issues. And in our country, there are a lot of obviously fertility issues regarding the family planning. A lot of women were anxious that they lost their follow-up for the fertility, and they were anxious regarding their treatment and the delay in their treatment. So those issues were addressed. Obviously, there were a lot of calls which were addressed regarding contraceptive options and how to get access to emergency contraception. And all of these were addressed through the phone call, and sometimes giving them prescription over the phone and sending actually them messages with sometimes with some of the medication. WHO and UNFPA during this initiative, which was very successful. And currently, the project is evaluated at the end because of at the end of the project, and it's not ready yet, the final evaluation, but from the midterm evaluation, it was a very successful and very excellent initiative. Next, please. As any initiative and new program, there were obviously some challenges that we have addressed by the collaborative effort and maintaining the initiative during the pandemic. It was also a collaborative effort to obtain and maintain the financial support for this initiative. One of the main challenges is reaching all women in the country and inform them regarding the presence of this initiative, because this service is quite unique and innovative, and that was not there in the country before. So people will need to know about it, and to basically, because we know that the need is there of the woman for this service, but social media had helped us a lot, and obviously the Oman TV and bulk SMS have also helped a lot in the media advertisement to disseminate the message. We have also, as I told you before, regarding prescribing medication, it was a little bit of a challenge, but then we have obtained also a phone line where we send the messages to the patient or to the woman with the correct spelling, obviously, of the prescribed medication. Next, please. So the key takeaway messages from this initiative, that it has highlighted the need for the innovative modalities to reach out to women and especially during difficult times like this. But also it has highlighted the need that this needs to be actually maintained and sustained, because the need is always there. The response from the women have improved through the course of the months by actually serving more women, and obviously strengthening our media advertisement campaign. There was wide range of women reached from different regions in Oman, addressing different issues, whether they are related to obstetric and gynecology or related to their inability or the best way to access the healthcare system. There was also some women who needed help during an emergencies, and that was also addressed, and it has actually give us the strength to say regarding the need, which is the major need there. The initiative have also addressed a collaborative effort, which is under the Ministry of Health Leadership and WHO Oman with the UNFPA and the OSOC. So what we are planning now is not only to to stop there. We are planning also to establish a platform, an online platform through the Ministry of Health website to sustain this initiative and make it as available to women to address their healthcare needs during the pandemic and afterward. Thank you so much for giving me this opportunity, and I will be happy to take any questions.
Thanks, Dr. Tamina, for taking us through that presentation. I have one question for you, and I would like to ask you what was the most challenge that you encountered, the most challenge, and how did you overcome that challenge?
In my opinion, Dr. Anthony, the main challenge was actually reaching the women and spreading the news, especially at the time of pandemic, because usually there are a lot of gatherings for women and women health, and it will be easier to spread. Obviously, social media had helped us a lot to reach for the women, and also strengthening the media advertisement through Oman TV and radio programs, and also through the bulk SMS.
So thanks a lot, Dr. Dugaisha, for that presentation and the nice response to the question.
Thank
now, ladies and gentlemen, dear participants, it's now my pleasure to end the first session with our panelists and move to the Q&A section. We shall be helped by the rapporteurs and who have been recording the questions. So I will request that you pose your questions, and then the panelists could make a response to those questions. So the floor is open now. This is to all panelists. How do you reach people who do not have access to internet? The all panelists, you could answer this. How do you reach people who don't have access to internet? I'll give you at the end a short time to respond to this. There is also another question: in which language counseling are given? Dr. Ture, please start with responding to reaching people in rural areas with limited internet. About Sayana Press, how can you introduce the self-care if we don't have before the DMP in our country? How can you introduce the self-care if we don't have the DMPA in our country? Self-injection is there, and DPMA, injectable Depo-Provera, is also there. Dr. Barije, you can clarify on that. There is also, Dr. Barije, thank you. This is Saro Nyango. Thank you for the presentation. Are women in these 4 countries now self-injecting, or is DMPA subcutaneous still provided by health workers and community health workers? Do the policies allow women to self-inject?
Thank you, Prof. I think a few questions which I need to respond to. One is on the introduction of self-care in the country and self-injection. I don't know where the person comes from, but we have different countries and they are at different levels. We have countries where they have had self-injection already introduced, and we have some countries which have not yet introduced that. But in these 4 countries that I presented about, they already have this. We have, like in Uganda, they have self-injection already introduced in those countries. And about the policies, each country obviously tries to work around the policies. In some places, they try to look at possibility of providing guidance. Like for example, we have Uganda where late last year actually, they did approve the scale up of self-injection in the whole country. So it is a country per country and looking at what supporting policies that are in place and what needs to be adjusted. Then the last question, thing which was posed to me was, how do we reach people with poor access to internet? Part of this is indeed part of the challenges which we noted. And I noted, like in my presentation, that we are exploring the possibility of transitioning to a platform that has an app which allows for somebody, for example, to be able to work offline. And then when the person gets access to internet, he can actually upload the work that he worked on. Then we are also exploring the possibility of working with audio alone and using the text. So all of these just require a simple phone, which may not actually smart and which may not require just a lot of internet connectivity. Over to you, moderator.
Thanks, George. Thanks, George, for those questions. Dr. Ture, could you respond to some of the questions, especially how do you reach women, people in rural areas who don't have internet?
Well, first of all, I'd like to say this. I was actually writing some responses to the questions in the Q&A box. But concerning our training activities and our online training activities, we organized different sessions, and we, of course, paid attention to prevention measures. As for our telemarketing, we used community means to carry out these different activities. I hope that I answered your question. And I'm going to keep on looking at the question and answer box to see what comes in. Actually, I wanted to mention one of the questions. There's one participant in this session who wanted to ask about the private sector's role and what were the major obstacles to including the private sector. I'd say that there are public sector actors who really are resistant to change. And they feel they feel like the private sector is a rival. So that does limit the private sector's participation. But in the certain region, we've had some initiatives where we've worked with government workers, and the governor agreed to open 2 centers managed by the private sector. Merci beaucoup.
Okay, thank you very much. Thank you. Merci beaucoup, Madame Touré. Thank you very much. We could now go to Dr. Tamina. You could answer a question on how you reach people in the rural areas without internet, and then any other specific question that has been posed to you. You have the floor, Dr. Tamina.
Thank you, Prof. Actually, our initiative, or it does not depend on the internet a lot. It depends on, obviously it's a hotline, so it's a telecommunication, and we have it available in the whole country. And the only thing is with the media, because the media, we had depend a lot on the social media, and obviously Oman TV and the radio, and the bulk SMS had helped a lot. So, and in general, in Oman, there are no issues with, internet is available mostly in the whole country, especially the highly populated areas. Now, there was another question, maybe I will answer very quickly regarding the initiative. So it started from March to December, so it ended, yes, in December. However, as I said before, we are planning to establish an online internet platform to address the issues and continue the telemedicine, I would say, initiative. The language was given in Arabic and English. And there was a question about which woman has approached mostly. It's mainly women who have fertility issues. And also we have a lot of calls regarding menstrual irregularities and what to do for them. Thank you, Professor.
Okay, thanks a lot. So maybe to sum up this scientific session, I would like to ask each panelist for final thoughts about what are the best lessons, what is the take-home message, and this is for each panelist. And we have two who are live on the audience, so you can please go ahead. This is our final session. We want the final thoughts. So who wants to go first? Ture, you started first. Would you want to start first? Final thoughts. Take home messages, please.
My dear participants, the private sector has accomplished extraordinary things, and the government need to follow up. So the way they managed the pandemic, so it was something difficult because when we had to have our bio assessment, so it's very important what I want to share. So when we had this situation of epidemic, so it's very important for us to continue responding to the need for family planning. And so we have to have a continuity and be able to respond to the population needs. So this is very important for us to be able to reach our objective of family planning, even by those difficult times.
Okay, merci beaucoup. Dr. Tamima, final thoughts in 1 minute. Final message to the audience.
Yes, Professor. So from our experience, actually, this experience has opened our minds to the need, to the actual need of reaching to women, not only through difficult times like this, also through the usual times, to basically address their healthcare needs. So the telemedicine is a very innovative and a very good way of doing that. And it's not only to sustain it during the pandemic, but we are also planning to sustain it overall in the country. And
Thank you very much.
And hopefully extending it to other different disciplines in healthcare, not only to obstetric and gynecology.
Thank you very much, Dr. Tamima. Dr. Barije, the final thoughts, final message in 1 minute.
Thank you, Prof. In some ways, I think that the pandemic has forced progress on remote and digital innovations. sooner than otherwise it may have happened. You'll note that more programs worldwide have renewed interest in digital training and supports approaches to keep family planning efforts more moving forward. So even among health workers in settings with limited technological capacity. So by leveraging digital platforms, programs can actually reduce, can be able to reduce the cost, time, inconvenience associated with the traditional classroom training, and reducing the need to pull critical health workers away from urgent demands. So while digital training does not completely replace invaluable in-person follow-up to ensure quality of care, it can actually be able to open the door to more flexible solutions, as family planning programs can combine approaches, including interim approaches depending on what meets their needs. So you know that more approaches are needed to reach health workers in local languages with lower tech solutions. So we noted mostly that actually most health workers don't have smartphones. They have a reliable phone, and they also don't have reliable phone or internet connectivity. So having low literacy or having the best reach in the local languages might actually be very helpful. And lastly, sustainability and capacity for scale up is definitely key.
Okay, thank you very much, George. Colleagues, ladies and gentlemen, I want to thank you all for today's discussion. This is the beginning of a conversation that we look forward to continuing to capture and reflect on emergent, important program implementation practices toward this International Conference on Family Planning. I want to specifically thank you, the panelists, for the exciting presentations, taking us through the best practices and lessons learned and take-home messages. I want to thank the audience for taking time and interest in this scientific panel. I hope we have lessons, we have lessons to take home and best practices back to our workplaces and countries. I would not leave here without thanking the co-chairs of the preparatory meeting for this scientific panel. I want to thank Dr. Benoit Kalasa, Technical Director at UNFPA, Madame Elaine Stambard, Director Population and Reproductive Health at USAID, Jane Graney at UNFPA, and me, Anthony Bonye from Makerere University. It was a pleasure and an honor to chair this scientific panel, and I'm so grateful that I was given opportunity to be part of this international conference and for this scientific panel. It is now my pleasure to say that this scientific panel is now closed, and you can leave at leisure and join other sessions. And thank you very much once again.
with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our